Many thanks for inviting me in. I thought I would just start with a little bit of background on who I am and what my background is as a foreigner and a foreigner with a funny accent. I thought that might be a useful way to start for me. So, I am a champion and advocate for addiction recovery, and I have worked in the addictions field since the early 90s. So, I've worked in a range of settings. Starting in clinical settings, I worked in a methadone maintenance clinic, a heroin detox ward. I've worked in an alcohol detox ward. And in the last 10 or 15 years, I've primarily researched around recovery. I've worked in clinical research and policy settings. So I'm an experienced academic. And the first thing I wanted to say is that people will have seen my name and potentially said, here is somebody on the recovery side of this debate. And I hope other people will say to you and have said to you that this is an unhelpful false dichotomy between recovery and harm reduction. And that essentially one of the key things, I guess, and not the most sophisticated lesson to learn is you don't recover if you're dead. And we need to have a system which allows people to stay alive long enough to enable and facilitate recovery. I also come at this from a slightly unusual angle, in as much as I am a criminologist. So I want to talk on some of the debate about crime and crime evidence as part of the discussion, but I will come on to this later. So much of my early work, when I worked in South London at the Institute of Psychiatry, was about peer use of naloxone. So I think it's really important that we have a recovery-oriented system that is predicated on a model of hope that ultimately aims to support people's individual journeys to recovery, but that system starts with community-focused harm reduction activities. So I want to make it clear, I reject the false dichotomy of recovery and harm reduction, but nonetheless, I will come at this primarily from a recovery perspective. There are two models that I would like to champion as part of that approach. The first is CHIME, that the fundamental aim we should have for all interventions are connections, hope, identity, meaning, and empowerment. And that the process for right across whatever system of care you use is fundamentally about that process of creating positive social connections that generate hope, that allow the building of positive identity, that give people meaningful activities, and that is something I will come back to, and that in turn allows effective empowerment of individuals. So the two fundamental premises for me are any part of a system, harm reduction, front end, community focus, right through to treatment pathways, are the importance of generating hope and aspirations for meaningful change. In outcome studies, and particularly the drug outcome research study in Scotland, DORIS, led by Neil McKechnie, people were asked, what do you want from interventions? Interventions right across the board. And fundamentally, people will say they want to lead a meaningful life that's free from problem drug use. In their survey, when asked about their aspirations, very, very few people answered that what they wanted was endless maintenance supply of drugs. And we get too bogged down in debates about segmentations of populations and utterly patronizing and unhelpful notions of some people are too complicated and too difficult and complex to hope for lasting change. But in my world of long-term recovery, we know that many of the people who effectively achieve lasting and stable recovery are people who would have been regarded as incredibly complex cases. And the treatment system cannot be paternalizing. It cannot segment off a hopeless group of people for whom the best we can hope is to keep people alive and keep people out of jail. For everybody, the aspiration should be about long-term change and the viability of long-term recovery. So anything that offers indefinite provision of substitution therapies of any kind is, in my view, massively risky, and the evidence in favour of those kind of interventions is fundamentally premised on a public health and a public safety model, not an individual well-being model. And it's crucially important that we have a model in place that inspires and provokes recovery. Now, as you will hear, the debates around safe consumption and the provision of medications of various kinds to people, the key is not the principle but the practice. And the practice of systems, and I want to go right back to the very start of my career when I was doing my PhD in Edinburgh. And at that time, in an attempt to control the spread of HIV in Edinburgh, a major risk to the population, the substance using population at that time, encouraged secondary distribution of methadone. Now, I then started interviewing people whose primary drug use was diverted methadone. And if you start providing a poorly regulated process and a poorly regulated market, you will create a secondary distribution network. It's also important to say, I think, that if we create centres, physical locations and centres, is around the challenge of the location and the management of the location. There has been some debate in the lead up to this select committee about crime and crime nexuses. Well, one of the things that I think is important to say, and then there have been challenges of the viability of your crime evidence around the way data is collected. But the history of criminology is predicated on the assumption that we are very poor at collecting crime data. Whichever measure you use, self-report, well, people will tend to report the crimes they've been caught for and not much else. Arrest data is basically a function of both policing priorities, policing resources, and the competence of the criminal. Conviction data and prison data, even more so. All crime data is flawed when we talk about reporting. So the two measures that you have used, public perceptions and police calls, are no more or less flawed than any other indicator. And what they represent, and from what I totally accept, you can't make causal claims, but you can very rarely make causal claims in social public policy debates in any case. What the data you have suggests is the problem of the social nexus of criminality. So where people congregate and there are identifiable, visible congregation points, you have high risk of normalizing substance use and behavior. And the other problem you have, as in my own previous experiences of being involved in injectable methadone clinics, is people then start to reject earlier options, lower tier options. Why should someone go through the drudgery of daily prescribed oral methadone when there are things potentially much, much appealing? And I guess given the cost typically of running safe consumption rooms and the cost effectiveness debates around safe consumption rooms, there are challenges to the number of places available. And we wouldn't want there to be a high number of places available for people to potentially access what should be a treatment effectively towards the last resort. And for me, the challenge fundamentally is around location. How do you avoid this becoming a location? And to give you an example of this, many years ago, I worked in South London at St Thomas's in a ward called MOPD4. And MOPD4 was a ward specifically for HIV-positive heroin injectors who were typically on very high doses of methadone and other prescribed medications. It became a nexus for bullying, and it became a nexus for diversion. The challenge there was people with HIV were typically given very high doses of methadone and benzos, and other people took them off them, bought them from them, diverted them, and they were used to fund other forms of drug use. The question is not whether it's appropriate to prescribe somebody, but how you can avoid some of those high-risk scenarios. And to link that to the Edinburgh study I mentioned earlier, the big problem is once you have diversion, you have a different set of risk factors of initiation and overdose of naive populations to whom the substances weren't prescribed or made available, linked to the complexities that drug use is typically not a rational process. It's driven at the high end of problematic use by compulsion, tolerance, withdrawals, and cravings that mean the planning of behaviours to get into specific sites to use in particular ways is challenging and problematic. So for me, the key kind of conclusions about this is you need to focus very much on questions of pathways in, pathways out. How you create recovery-oriented, hope-based models, even for people who engage in safe injecting facilities or safe consumption facilities. You need to create expectations and beliefs throughout the system that this is not simply an alternative to standard treatment processes. And you need to think very, very carefully about how you create meaningful pathways to and through those systems that are associated with logistics that avoid crime nexus, that avoid diversion and leakage of drugs into the community, and that avoid creating normalization and normalized expectations of serious and problematic substance use. And that cannot be on an indefinite or maintenance basis, because effectively what you then create is a public health, public safety crisis at the cost of individual well-being and choice. I think just to conclude, what for me is a challenge here is that you provide a very small level of provision at a very high cost for a small number of individuals that, while it may evaluate positively from a satisfaction and experiential point of view, doesn't provide the level of long-term change and hope to individuals, but not only to individuals, because we learn from recovery models. The goal is a ripple effect from the individual to the family and the community. And any evaluation has to be relative to recovery-oriented models that attempt to provide provision that is effective across all of these three populations. And that the beneficiaries of any intervention within a recovery-oriented model, which you should have, has to take into account all three of those populations moving forward. I see my clock is down to 9 seconds, so I will stop at that point.
Thank you, Dr. Best. We'll now open up for question and answer with the members here, and we'll start with MLA Milliken.
Thank you, Chair, and thank you very much for your passionate presentation. Came across, and I can see, based on the fact that I think through your background, you having experiences not just sort of philosophically about these kind of issues, but also on the ground and actually hands-on. You mentioned at one point that you were in there actually doing the interviews, and that comes across with your level of knowledge. So I do want to thank you for that. I also like the logic of just listening with regards to this hope-based model for meaningful change and a meaningful life being one of the main points of what addicts often are looking for, flushed out from your interviews. So I guess one of the things, though, that I have a question on is you mentioned that diversion is something that you can pretty much expect. I was wondering if you could maybe expand on that, because jurisdictions with safe supply, they experience diversion. I was wondering if you could explain a little bit as to why it happens, and perhaps if there's any kind of mitigating factors to try to stop it as well.
Yeah, sure. So I think let's start with the principles and experience of diversion. People generally don't want to take their drugs in stigmatizing clinics in sterile clinical conditions. So we generally operate on a contingency model where if people are using in a controlled way, they are allowed to take homes. And I'll give you my own experience of methadone maintenance clinic in South London in Camberwell, where I worked for 2 or 3 years. We had our own on-site pharmacy, and people would generally Monday to Friday be dispensed to in the clinic. They would have to be breathalyzed to make sure they weren't alcohol intoxicated to avoid central nervous system depressant overdoses. They'd be provided with their medication. They would have to take some orange juice or water afterwards to ensure there would be no spitbacks, and they would leave. But it was open from 9 to 5, Monday to Friday. On Friday nights, people would get takeaways, simply on cost effectiveness and staffing grounds. And for roughly a quarter of our clients, Friday night would be party night. They would take their weekend take-homes, and they would go down to Camberwell Green, just a few hundred yards away, and they would swap, they would sell, they would use, and they would use a combination of things. And by far, this is certainly not everyone, but a significant proportion. We had around 400 clients in that clinic. And the problem we had was that they were not using according to the guidelines and recommendations. So they would sell and buy Monday morning. And when I would arrive at work at 8:30 on Monday morning, there'd be a large number of people in severe withdrawals because they either sold their methadone or swapped their methadone, and they were then withdrawing over the weekend. And one of the challenges of prescription-based systems is the problem of non-compliance and the management of non-compliance. So we had problems of combination with alcohol, of benzodiazepine use, prescribed and non-prescribed, and the challenge of systems. And as a criminologist, you have multiple sources of potential leakage. You have staff sources of leakage, and you have client sources of leakage. Unless you're going to operate a system that's 24 hours a day, 7 days a week, 52 weeks a year, you will face significant challenges of diversion of substances. Diversion of substances is problematic in a couple of ways. One, it means non-compliance with whatever regime they were prescribed under, and two, potential leakage to vulnerable non-using groups and populations. And I think one of the big challenges you have, and it's a valuable commodity, and the purer the substances you provide and the further away you move from things like methadone linked to, the higher the risk of both diversion and the creation of an illicit market around those clinics and communities. And this is where the danger of the drug crime nexus potentially grows.
Follow-up, member?
I guess what I do is just switching course a little bit is what are the objective measures to determine whether safe supply is effective?
I mean, I guess that they would be potentially predicated at three levels. So you'll have the individual level where traditionally there would be health measures and the traditional measures of drug treatment outcomes, which would be in 6 different domains. Impact on substance use, so illicit substance use, external illicit substance use, physical health, psychological health, social networks, meaningful activities, families, and criminality. So that would be the individual level. From my point of view, as a recovery advocate, I would also add to that citizenship and global well-being and quality of life. And I think one of the challenges about potentially offering something that may reduce the likelihood of moving towards recovery-oriented or abstinence-oriented models is, are you potentially reducing the likelihood of the person achieving employment, achieving reunification of families? Now, one of the things that I've always thought was a myth and a shibboleth was the idea that there is a substantial proportion of medicated populations who are high functioning and achieve these things regardless. And I think one of the challenges of this question is really around what measures you have. So they would be the individual measures of well-being. You then would add to that potentially family measures and community measures. So you have measures of community satisfaction. The notion of outcome is not a simple measure. And one of the things we've learned from a recovery model is we switch from thinking of the individual as the unit of analysis to the individual being part of a broader system of how does it impact on the individual, how does it impact on their family, how does it impact on their neighbourhood, and how does it impact on their community. So public health and public safety are kind of community factors, but there are broader factors we'd want to look at as well. Sorry if that was too messy an academic answer.
Thank you, Doctor. Next up, we have MLA Yao.
Thank you so much, Chair. And Dr. Best, thank you so much for taking the time to speak to us and our committee. It's greatly appreciated. I just want to reflect on some of the comments you made and just clarify the context, if you will. And I'll finalize it with just a final question to you. You talk about trying to keeping people alive until they can be treated, and you talk about recovery systems that respect the individuals, and that the models must promote things like positive social connections, meaningful activities, etc. And then you kind of talk about how, or you mentioned that some people will reject lower tier options like oral methadone for other alternatives. I guess my question to you, based on all these comments, is that in the field of addictions, are there truly substantive options available for those for the addicted individuals, or are we, or is providing the actual pharmaceuticals or drugs a very clear and patent reasonable treatment for people? Thank you.
Okay, thank you very much for the question. The first thing I'd want to say is, from the best evidence we have available, of all people who have a lifetime substance use disorder, 58% will eventually achieve stable recovery, meaning 5 years of continuous sobriety at some point in their journey. So we know that for the majority of people, long-time recovery-oriented change is a viable option. So, which also obviously leaves you with the corollary or the flip side, which is 42% of people don't. I think one of the dangers has been that we potentially are too inclined, far too quick in systems terms, to write people off and consign them to that world of saying, well, the best we can hope for you is to keep you alive and keep you out of prison. One of the great successes of recovery models, and one of the things that has astonished me throughout my career in different countries, including Canada, has been the astonishing capacity and resilience, particularly of peer-based models, to support people into recovery. Now, I think for me, this is a question of mechanics, not a question of philosophy or principle. I have no problem with the idea of substitute prescribing. I have no problem with the idea of overdose prevention, naloxone programs, needle exchanges, or indeed safe consumption sites, on the grounds that they are predicated and embedded within a peer-based, recovery-oriented model of care. So the idea would be nobody gets stuck in methadone or any other form of parking lot, that we don't just abandon people. And look, there's a huge danger. One of the most contentious studies I've ever done, and I apologize for going back to methadone prescribing, but it's relevant to this point, is that the idea of substitute prescriptions is there's three component parts. There's the substitution pharmacotherapy, there's the psychosocial intervention, and there's care and case management. Well, when I did a study in Birmingham, we looked at every person who was engaged in substitute prescribing in Birmingham, and on average, they were seen once a month for an average of 9 minutes. And the danger is the pharmaceutical intervention, the pharmacotherapy dominates, and nothing else happens. And so the mechanics of treatment has to include this much broader psychosocial path and psychosocial support system. And, for me, it's not about whether you provide any particular interventions. It's how it's part of a broader model of care that offers a genuine chance for family, meaningful activity, employment, decent housing and education. And if you offer something like safe consumption as a standalone intervention for a small group of people, it doesn't help your system and it doesn't do any of those challenge, stigma and reintegration things.
Thank you. Yeah. Follow up.
And just a very quickly follow up, actually a question provided by my good friend from Banff, Kananaskis. You mentioned that 58% of addicts will recover on their own initiative. Does that number decrease where safe supply exists, or does it increase? Is it a factor in areas that do provide safe supply? Thank you.
Yeah, I mean, the evidence simply, and let me be clear, I didn't say people recover on their own. I said 58% of people will eventually achieve stable recovery. We don't have good enough evidence to say what the community factors are that predict that and how much that's related to safe supply. And I don't think safe supply is sufficiently either uniform or evidenced as a mechanism of change to allow us to assess the attribution of that figure. So my apologies, I don't think the science is good enough to tell us that at this stage.
Thank you, member. Next, we have MLA Fry.
Thank you very much. My question is based along your comments about recovery-oriented care. So our government has been very bullish on this. We've said very publicly, our minister has stated it, we've stated it, we are looking at a recovery-oriented continuum of care. So to me, the idea of safe supply kind of flies in the face of that recovery-oriented system of care or continuum of care. But I also see that there are harm reduction techniques that can be used to achieve that end. So I was just wondering if you could expand on your experience and the experience that you've seen. What harm reduction techniques are the most effective at achieving a recovery-oriented system of care, and which are the most detrimental to that?
Yeah. Let me just say that the whole idea of a recovery-oriented approach or a recovery-oriented system is predicated on the notion of continuum of care. So it's entirely consistent with the notion that you will attempt to engage people in recovery interventions from their first contact, whether that's with a needle exchange, whether it's with a prescribing clinic, or indeed with a safe consumption room. The idea would be to say, for people, we meet people where they are and we work with them towards that model. Now, some of the most wonderful and effective recovery-oriented systems pick people up in accident and emergency rooms, pick people up at the gates of prison and take them to mutual aid or 12-step meetings, get them involved in recovery housing, get them involved in peer-based recovery support services. The starting point is not so important. The focus on medication, the focus on providing safe supply, to me is secondary to the how it's done and the why it's done. If you ask me about what a recovery-oriented system in practice means, it's a recalibration of the allocation of resources, much, much more to community-focused, strengths-based reintegration efforts. But it doesn't mean that those things couldn't be done within an entire gamut of harm reduction services. Now, it seems perfectly legitimate to me. You asked me about the most effective. I think something like Take Home Naloxone works beautifully. So potentially somebody coming out of prison who is going to meet somebody to take a peer to take them to a recovery residence, take them to a 12-step meeting, but they have naloxone in their backpack when they come out. That seems to me a beautiful alignment of the two things. There's a safety net, but there's a pathway to long-term change. The challenge once you go down the road of prescribing services is they create networks, they create expectations, beliefs, and identities, frequently stigmatized identities, that are hard to reconcile. So the mechanisms through which they are set up, through which diversion is prevented to prevent significant community harms, and through which hope and aspirations, meaningful aspirations for change is crucial. So I think in some ways I'd want to avoid kind of league tabling or ranking harm reduction interventions, because for me the crucial point is how they can be utilized to initiate the process of what will typically be community-based and peer-delivered approaches to recovery-oriented models, which are increasingly strongly evidenced that what we want to do, even for somebody in a safe consumption room, is to start identifying what recovery capital they have and how we can use peers, social networks, and community resources to build that recovery capital, way beyond the point they'd want to use a safe consumption room or a methadone prescription.
Is there a follow-up, member?
No, and I'm sorry, Mr. Chair, I have to turn off my video from time to time or else I start to lose my internet connection.
MLA Stefan.
Sure. Thank you for that presentation. I just have a question about the argument that you sometimes hear in respect of self-supply, that there are some who are suffering under these addictions that are not interested in recovery, and that the opportunity to keep them alive is an ends that justifies the means of self-supply or safe supply. I'm just wondering if you could speak to that argument, that someone who is alive has a chance in the future of recovery, and that somehow safe supply keeps them alive. Thanks.
I have absolutely no problem with that argument. As you're probably aware, and I'm sure you're aware, the question of motivation is a really complex, fragile and changeable thing. So the notion that somebody is interested or isn't interested in recovery seems to me almost a misleading concept, and its exposure to successful recovery peers and recovery groups and recovery organizations that inspires and promotes change. I don't see any of these things as kind of blocks of things that happen inside people's heads. And I'm not particularly wedded to or convinced by any of those clinical arguments that would say somebody is too addicted or too complex or too messy to be thinking about recovery models. I think that's paternalizing and dismissive and problematic. The other part of your comment and question of do we need to provide supports and medications to allow individuals to stabilize, to enable them to benefit from recovery models? Absolutely. Now, I think there's a significant challenge around the duration and the intensity of that offer. I think we have to offer recovery-oriented models at every point, in safe consumption rooms, in prescribing clinics, in needle exchanges, because the ultimate point of a recovery model is not to write people off. Everybody should have that hope of change and be exposed to role models and successes that allow them to aspire to and believe in and be part of that change model. And that's a very different kind of social network and social identity, the kind that may well be at risk of happening in maintenance clinics and safe consumption sites, where an entirely different socio-cultural and value set of identities and expectations linked to stigmatization accompanies that approach and that model. So for me, I think, yes, of course, you have to keep people alive and you have to offer, any recovery-oriented system has to have a full range of options. But the weight and the emphasis and the strength is on creating hope and supporting change.
MLA Amory with about a minute left.
And thank you, Dr. Best, for providing us with your presentation and your perspective as it relates to your observations and findings. I note from your bio that your research interests include things like recovery pathways, recovery capital and its measurement, social identity theory and implications for recovery, addictions treatment effectiveness, and family experiences of addiction and recovery, among other areas, of course, that you have undoubtedly evaluated. Your area of expertise and your focus of study appear to be recovery-based. Yet this committee here is contemplating the viability of quote-unquote safe supply. It's become clear from our work here, even just today from the people that we spoke to, including yourself, that safe supply is not really a uniform theory. That means that the jurisdictions that have embraced this concept have different methodologies and applications, and I think that's fine. I mean, different jurisdictions have different challenges, and therefore I think have to apply models that work for them. Dr. Best, my preamble was long, but my question is going to be quick and simple. I want to know whether there is any evidence that you can describe to this committee or that you are aware of which reconciles the concept of safe supply and addiction recovery. And in simpler terms, just to kind of narrow it down a little bit, for the uninitiated like me, it appears for me that the two cannot be reconciled. I'm not sure that supplying those with the very substances that lead them into addiction recovery is the answer. Am I wrong?
Okay, no, you're not wrong. I mean, I would just want to quickly say that although I'm a recovery advocate, champion, and researcher, my background and my history as an academic is in clinical research and treatment services, including a diverse range of harm reduction experiences. I have no direct experience of safe supply. I would not prioritize safe supply within a recovery-oriented model, but I cannot provide you with evidence that says they are inconsistent or contradictory. Safe supply, if it's going to be embedded, has to be within a recovery-oriented approach and has to fulfill the criteria of moving people forward as much as possible into recovery-oriented models. I'm sorry, that's a far too short answer to what's a very big question.
That's quite okay, because we actually ran out of time there. So I'm sure we could have spent a lot more time asking questions, and we are very much appreciative of the time that you did take with us and your presentation, and feel free to join us for the rest of the afternoon as well if you're interested. So thank you, Dr. Best.
Many thanks.
Sincerely appreciate you. Thank you.